section on ultra rapid revision of surgery through images part 4. My name is Dr. Jhanvi and I'm the anesthesia educator on Unacademy. And today we will be continuing with our very popular series in which we are going to complete the entire surgery class portion that we have for your NEET PG as well as FMGE exam. So all those of you who are new to this series, we have already completed the whole of esophagus, the whole of oral cavity, salivary glands and neck swellings and all the swellings that are asked in surgery. And this is our fourth class today. Today we are going to be doing stomach and duodenum. First of all, I hope that you guys are able to see me and hear me well. If the streaming is okay, please leave a thumbs up in the chat box. Yes, I can see that the streaming is absolutely fine. So we can begin with the class. Welcome to Unacademy. This is our Telegram channel, Let's Crack NEET PG, where you will be getting the links to all the classes that we take. These are all free classes available on YouTube and you can make use of this for your preparation. These are all our FMG toppers. The Plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators. You can compete in live tests and quizzes. You can study on the device of your choice. The iconic subscription is a partnership between Unacademy and PrepLadder. Here you can get the live lectures of Unacademy along with the video lectures of PrepLadder. In our special classes, we have features like interaction with the educator, you have polls, you have raise a hand option, you have never miss a class option, so you will get notified about the class prior and you will get lecture notes as PDF at the end of the class. Our highly effective question bank will help you solve 25,000 plus questions and any question that comes in any exam. We have raise a hand option in which you can speak to the educator live during the class. And these are the current batches that are going on: the Target NEET PG 2022 MCQ discussion batch, FMGE 2022 comprehensive batch. And this is our free test calendar where you have tests coming up every other day that you can avail for free on the Unacademy app. This is for those giving the exam in 2023, the Target Next Integrated System-Wise batch. And for all of you who want to join any of these batches or all of these batches, you just need one single Unacademy subscription. And when you buy the subscription, you can use my code Dr.Jhanvi Live to get an extra 10% off on your subscription. So with that, let's begin with our first question for today. So as I told you guys prior, we are going to be doing stomach and duodenum today. All right. So this is our first question for today. 90% of duodenal ulcers are found in this part of the duodenum. First, second, third or fourth? So can you guys answer? Mulay is saying second part of duodenum. Any other answers do we have? Quickly answer. Staphylococcus is saying in the third part of the duodenum. Alright, so guys, first of all, see what I'm asking you over here. I'm asking you about duodenal ulcers. Don't go to the answer for peptic ulcers, okay? Peptic ulcers are the ulcers that are present in the stomach and in the duodenum. Here I am asking you simply about duodenal ulcers and where are 90% of the duodenal ulcers found. Alright, so Faiz, Sujata, Faisal and Faisal are absolutely correct. The 90% of duodenal ulcers are found in the first part of the duodenum. Okay, so before we go on to things about the duodenum, I just want to tell you some important features of the duodenum that come in your exam as one-liners. Okay, so first they will ask you what is the extent of the duodenum. This you should be knowing for your exam. So can anyone tell me from where to where does the duodenum extend and how many parts are there of the duodenum? How many parts are there of the duodenum? Where does the duodenum extend? Now, about each part, you need to know one specific feature. So, like I will tell you over here, extent of the duodenum actually starts from the pylorus of the stomach. Okay, so there will be a sphincter over there at the level of the pylorus. Here, if I draw over here, your pyloric sphincter is here. After the pyloric sphincter starts your duodenum. Okay, so from the pyloric sphincter, and where does it end? It ends at the ligament of Treves. So this comes in the exam as a question. Please remember this. Next thing that they will ask you is what is significant about each part of the duodenum. Okay, so first part, second part, third part, and fourth part. So I'll tell you one liner of each. So first part of duodenum, as I told you, most of the duodenal ulcers, 90% of the duodenal ulcers occur in the first part of the duodenum. Okay, this first part of the duodenum that is present, it is like this. It is also called as a duodenal bulb. It looks like a cap, so it can also be called as a duodenal cap. Okay, so duodenal bulb or duodenal cap. The second thing that they will ask you is about the second part of the duodenum. Anything that you guys know about the second part of the duodenum? Anything that is present over there coming from the common bile duct and the pancreatic duct? Yes, absolutely correct. So the common bile duct and the pancreatic duct, both of them will merge in the second part of the duodenum at the ampulla of Vater. Okay, at the ampulla of Vater. So that is what we need to remember about second part of duodenum. Now, the third part of duodenum, sometimes they ask you questions, where exactly is it present? So it is present between two major arteries. It is present between the aorta and the superior mesenteric artery. So that is what you need to know about the third part of the duodenum. Okay, so one liners about the duodenum. All of these have come in previous year's exams, and that's why I have included it for you all over here. All right. Okay, moving on to our next question. Identify the part of the stomach that is marked over here. So I am shading a part of the stomach over here. You can see the white part that I have shaded above this part. I want you to identify the part of the stomach. Cardia, fundus, body, or antrum. Identify the part of the stomach that is marked. Cardia, fundus, body, or antrum of the stomach. Okay. So Rajesh is saying fundus. Any other answers? Okay, everyone is saying that is the fundus. Absolutely correct. Very good. Okay, so we'll mark all the parts of the stomach, and that's how you will be able to identify it. So this part which is coming from above is nothing but the esophagus. All right. This part over here that you can see, this is the fundus of the stomach. Okay, this is where you see the fundic gas bubble or the air settles on top. So that is the fundus of the stomach. All right. Then after this, what you see, this entire part is the body of the stomach. All right. After the body of the stomach, this is the part between here, the body and the pyloric sphincter, and this is called as the antrum of the stomach. Okay, this is the antrum of the stomach, and then here you have the duodenal cap. So where exactly do you have the cardia of the stomach? Okay, so this part of the stomach that is joining the lower part of the esophagus over here. Okay, here I have marked it, I've shaded it in white. That part is called as the cardia of the stomach. All right, so these are all the parts of the stomach. In your exam, they can mark any one part and they can ask you to identify. So in this picture, I have marked all the parts of the stomach that you need to know. All right, remember guys, whenever you study surgery, you have to study from the very basics, that is from the anatomy. And in the anatomy, they will ask you the parts. Sometimes they can ask you the histological types, the cells that are present inside the stomach, and arterial, venous supply, lymphatic drainage. That is also very important. Okay, so we'll be covering all of that. Then we'll be moving to the pathology. Okay, all right. So now I have a question for you guys. Left gastric artery is a branch of gastroduodenal artery, hepatic artery, splenic artery, or celiac artery. This is one of the favorite questions that comes in the exam. They will ask you the arterial supply of the stomach, and then out of any of those arteries, they will ask you one of the major, that artery is a branch of which artery. Okay, one of the very common questions that comes in the exam. Okay, so I'm getting all different answers. Staphylococcus is saying GDA, Sujata is saying B, hepatic artery, Fez and Faisal are saying D, celiac artery. Okay, so all different answers over here. So let me give you the answer. The left gastric artery is a branch of the celiac artery. And where is the celiac artery coming from? Celiac artery is coming from the aorta. Okay, so now let's have a look at all the blood vessels that are supplying the stomach. Okay, so all the blood vessels that are supplying the stomach, and where do they arise from? Okay, so you have to know the names and where they arise from. So first we'll be doing arterial supply, left gastric artery that arises from the celiac artery. Okay, so along with me you can also revise from where all are the blood vessels coming. Then you have right gastric artery. Okay, and this right gastric artery arises from which artery? It arises from the hepatic artery. Okay, so now remember, one more branch arises from the hepatic artery, and that is our gastroduodenal artery. Okay, that is the largest branch that is supplying the stomach, and that also arises from the hepatic artery. In fact, sometimes they ask this in the exam, what is the largest branch of the hepatic artery? So the largest branch of the hepatic artery is the gastroduodenal artery. Okay, any other branches that you can remember? Okay, so if you look over here, the greater curvature of the stomach, you are having left gastroepiploic artery, and here you are having the right gastroepiploic artery. So we also have to talk about the gastroepiploic arteries. Okay, so you can see the left gastroepiploic is very close to the spleen and the splenic artery. So the left gastroepiploic artery, if you look in the picture, from the picture only it's very easy to identify what is coming from where. Okay, so left gastroepiploic artery arises from the splenic artery, and your right gastroepiploic artery. Now your right gastroepiploic artery is on this side. Okay, it's more on the righter side. It's not towards the spleen. So that is coming from your gastroduodenal artery. Okay, so it is a branch of the, if we talk about the right gastroepiploic artery, that is a branch of your gastroduodenal artery, which is a branch of your hepatic artery. Okay, so if you see, most of the arteries that are coming from the right side, your right gastric artery, then your right gastroepiploic artery, all of them arise from the hepatic artery. Okay, and those things that are coming from the left side, like your left gastroepiploic artery, are coming from the splenic artery. Okay, so that's how you remember all of them. Then you also have one important question that comes in the exam about the short gastric arteries. Okay, so your short gastric arteries, they are present on the left side. So as I told you, if they are arising from the left side, so your short gastric arteries are also arising from your splenic artery. Okay, so this is all about the arterial supply of your stomach. Very, very important question. It has come, in fact, many times in the exam. Okay, now what about the venous drainage of the stomach? So can anyone tell me about any of the important venous drainage that you know about? Okay, I'll take the name of the vein, and then you can tell me that vein drains into which vein, which main vein. Okay, so we have the right and left gastric veins. These are the main veins that drain the stomach. So tell me, where do they drain into eventually? Then we have the right gastroepiploic vein. All these veins will accompany the arteries along with it. Okay, and then we have the left gastroepiploic vein. These are the main veins that drain the stomach. So can anyone tell me the right and left gastric veins will drain into which vein? Okay, yeah, very good. So the right and left gastric veins will drain into the portal vein, because the portal vein is the biggest vein that is present in the body, correct? In the lower part of the body, it will literally all the viscera, all the veins of supplying the stomach, duodenum, colon, everything eventually drains into the portal vein. Okay, so the right and left gastric vein drains into the portal vein. The right gastroepiploic vein is more on the right side. Okay, so it will drain into the superior mesenteric vein, and the left gastroepiploic vein is more towards the left side, so it will drain into the splenic vein. Okay, so this is all that you need to know about the arterial and the venous supply of the stomach. All right, moving on to our next question about the nervous system that supplies the stomach. So this is your question. The antral pump is innervated by criminal nerves of Gracie, nerves of Laterjet, submucous plexus of Messner, or myenteric plexus of Auerbach. So here, what am I asking you exactly? If you have a look in the previous picture that I had shown you, so this is your antrum, correct? This is the part which is the antrum, and this is the part which propels or pushes the food forward through the pyloric sphincter into the duodenum. Okay, So now you need to tell me, to push this food forward, there has to be coordinated contraction of that part of the antrum. So that is called as the antral pump. So what is the nervous system supply of the antral pump? What is the innervation of the antral pump? Okay, so here Pez is saying that the answer is nerves of lateral jet. Staphylococcus is saying C, submucous plexus of Messner. Any other answers, guys? Okay. Chalo, batao. Rajesh, Faisal, anyone? Submucous plexus of Messner. Okay. So the correct answer over here is nerves of lateral jet, because we are specifically talking about the antral pump. The antral pump is provided innervation by the nerves of lateral jet. Okay. Now let's have a look at the different parts of the stomach and what is their innervation. So now intrinsic innervation, you have extrinsic innervation and you have intrinsic innervation. Okay, in the stomach. All of you all know who supplies the extrinsic innervation of the stomach? Please tell me which is the nerve that supplies the extrinsic innervation of the stomach. Okay, so everyone knows the vagus nerve supplies the extrinsic innervation of the stomach. Okay, and sometimes they will ask you as one of these statements is false. So you have the left sided vagus nerve which supplies the greater curvature, and you have the right vagus nerve which supplies the lesser curvature of the stomach. Okay, now just remember this, if you are able to, the left vagus nerve is anterior and the right vagus nerve is posterior. Okay, this is one of the questions that has come in the exam. They will just turn it around and say right is anterior, left is posterior. So that is the false statement that you need to remember. Now, why is that important to remember? Because when they do a vagotomy, for most of your gastric ulcers, you have to do a vagotomy. So you need to know which one is the anterior nerve, which one is the posterior nerve, which part is supplying the lesser curvature, which part is supplying the greater curvature. Okay, all right. Then the next thing that you need to know about this is which part of the vagus supplies the antrum. So that was the question that I had asked you. The antral pump is supplied by nerves of lateral jet. Okay, so these nerves of lateral jet also come directly from the trunk of the vagus. All right. Now, what about the intrinsic innervation of the stomach? So the intrinsic innervation means in between the muscles there will be a plexus of nerves. So this plexus of nerves has two names. One is called as the myenteric plexus of Orbach, and the second one is your submucous plexus of Meissner. Okay, and they are present throughout the muscularis of the stomach. So that is the intrinsic innervation of the stomach that you need to know. So in your exam, they will directly ask you what is the intrinsic innervation of the stomach. So you need to just answer as Orbach and Meissner. Okay, now there is one more nervous system component that you need to know about, that is asked in the exam, and that is very, very important. Now I don't have space here, but I'm writing it. I hope you understand. So that is criminal nerves of Gracie. This is also asked many times in the exam. All these special things ना they like to ask, because they feel अरे ऐसा सब पूछेंगे तो किसी को आएगा नहीं, no one will read so much in detail. So whenever all these nerves are there ना with special names, you should try to remember it for the exam. Okay, now your criminal nerves of Gracie also are extrinsic innervation. They arise from the vagus only, and they supply the lower part of esophagus and the upper part of the stomach, or the fundus of the stomach. All right, so I know I've written it ekdam niche se chotu chotu mein, but I hope you guys are able to understand what I have written. If you can't, please let me know. I can erase it and write it again. All right, so this is everything about your innervation of the stomach. So we've seen the parts of the stomach, we've seen arterial supply, venous supply, and we have seen the nervous supply of the stomach. All right, now moving on to the cells that are present in the stomach. So this is the question that comes in the exam. Pepsinogen 1 is produced in the stomach by chief cells, parietal cells, endocrine cells, or oxyntic cells. So we have different cells in the stomach. We need to know what each of these cells secrete. Very important from the exam point of view. So you have to tell me pepsinogen 1 is produced by which cells? Okay. So Staphylococcus is saying oxyntic cells. Any other answers? Rita is saying chief cells. Sujata is also saying oxyntic cells. In some is saying chief cells. All right. So, guys, the correct answer is chief cells. Okay, pepsinogen 1 is produced in the stomach by chief cells. Now, your oxyntic cells that I have written over here is nothing but other name for your parietal cells only. So, literally, option B and D are the same. Okay. So, when we talk about all the cells, your chief cells are also called as zymogenic cells. Zymogenic cells, and your oxyntic cells or your parietal cells are also called as oxyntic cells, one in the same thing. All right, so now can you all tell me, I'll write the name of the cell and you have to tell me what does it produce. Okay, so the first thing you have to tell me what does the chief cell produce. So we have already seen it produces pepsinogen. Okay, now this pepsinogen and chief cell is also called as zymogenic cell. Okay, so they can also give that in the option instead of giving chief cell. Chief cell. So now you have pepsinogen. Pepsinogen ka two types are there. Pepsinogen 1, pepsinogen 2. Okay, now you don't need to know exactly what is the difference between pepsinogen 1, pepsinogen 2. You just have to remember it helps in breaking down the protein component of the food. All right. Now, the second type of cell that we have is the parietal cell. So can you tell me what all is produced by the parietal cells? These parietal cells are also called as oxyntic cells. Then the third type of cell that we have is the endocrine cells. So what are the hormones produced by the endocrine cells? Endocrine cells may, in fact, we have two types of cells. We have G cell and we have D cell. So you have to tell me what is produced by each of them. Yes, very good, Rita. So the parietal cells will produce hydrochloric acid. Anything else that the parietal cell produces other than hydrochloric acid? One more thing, it helps in vitamin B12 absorption in the body. If you there is a autoimmune disease in which this is absent. In fact, there is parietal cell destruction because of autoimmune cells, immune bodies, and then you have reduced B12. Yeah, very good. So intrinsic factor is also produced by your parietal cells. Absolutely correct. Okay, so your parietal cells produce hydrochloric acid and intrinsic factor. Intrinsic factor is required for the absorption of your vitamin B12. Okay, now endocrine cells may you have G cells and you have D cells, and these endocrine cells are mainly present in the antrum of the stomach. So the G cells produce gastrin and the D cells produce somatostatin. All right, so this is about the endocrine the cells. Then you also have mucus cells that are present. Okay, and these mucus cells produce nothing but gastric mucus. Why do you need gastric mucus? So gastric mucus basically forms a lining along the entire stomach so that the stomach is not corroded by the hydrochloric acid that is being produced by the parietal cells. Okay, so it maintains the integrity of the gastric mucosa. That's it. So these are all the different types of cells that we have and all the things that they produce in the exam. All the things that they produce, and this can come for your exam. All right. Now, the next question that I have for you guys, a little bit about the duodenum. We saw the parts of the duodenum. I want you to answer the sympathetic supply of the duodenum. Now, if you see the arterial and the venous supply of the duodenum is not very different. I will discuss that with you all. But this is one of the important questions that can come for your exam. The sympathetic supply of the duodenum is from T6 to T8, T7 to T9, T8 to T10 or T9 to T11. So we've seen the arterial supply, venous drainage, nervous supply and the cells of the stomach. So and we have seen the parts of the stomach. Now we have already seen parts of the duodenum. So we'll do the arterial supply, venous drainage and nervous supply of the duodenum. Okay. Okay, so all of you all are saying T8 to T10. Very good. That is the correct answer. Okay. All right. So now tell me what is the arterial supply of the duodenum? Anyone, any idea what is the arterial supply of the duodenum? It's very, very easy. Then the venous drainage is also very easy. Everything is very easy once you know it and once you revise it. Okay. And then you have the nervous supply. Okay. So we'll start off with the easiest thing over here. The easiest thing over here is your nervous supply. Okay. So in your nervous supply, you have sympathetic and you have parasympathetic. Okay. So the sympathetic supply is by T8 to T10 spinal nerves. Okay. And your parasympathetic is by the vagus nerve, same as the stomach. All right. Now, in your arterial supply, you have mainly the upper part of the duodenum, or the starting parts of the duodenum, that is supplied by the superior pancreatico-duodenal artery, and the lower parts are supplied by the inferior pancreatico-duodenal artery. Now, why have I written them separately? Because they are arising from different arteries. Okay. So, your superior pancreatico-duodenal artery is arising from the gastroduodenal artery, and your inferior pancreatico-duodenal is arising from the SMA. Alright. And the venous drainage of your stomach, just try to remember all the veins that are there around. So, you have mainly your splenic vein and your portal vein that is there. Okay. So it all drains into the splenic vein, portal vein, and superior mesenteric vein. Okay. So this is about your arterial supply, venous drainage, and nerve supply of the stomach. Alright. Now moving on to the of the duodenum. Now moving on to the physiology of the stomach. Which of these is not a phase of gastric acid secretion? Cephalic phase, esophageal phase, gastric phase, intestinal phase. Alright, so doctor and caffeine is saying D. Phase is also saying D. Intestinal phase is not there. Mulai is saying esophageal phase is not there. Any other answers? Insam is also saying D. Subham is saying B. Alright, so the correct answer over here is actually B. Okay. Esophageal phase is not a phase of gastric acid secretion. So now you need to know what are the phases of gastric acid secretion. Sorry, I'm so sorry. Okay, so the first phase of gastric acid secretion. Now you just start imagining, you guys are the food is kept in front of you. There is a plate of, let's say, pav bhaji. Okay, so the first phase that will be there is the cephalic phase. The first phase that will be there is the cephalic phase. Now cephalic phase is when you actually look at the pav bhaji, and what will you get stimulated by? You will get stimulated by the smell of pav bhaji, by the sight of pav bhaji, and the taste that you remember of pav bhaji. Okay, so that will stimulate your vagus nerve. The sight and the smell will stimulate your vagus nerve. The vagus nerve will then produce acetylcholine, which will activate the muscarinic receptors that are there in the stomach. Okay, so that is the first phase, which will lead to production of hydrochloric acid. That is the cephalic phase. Okay, then the next phase that we have is the gastric phase. So gastric phase is once the food enters into the stomach. Okay, so when the food enters into the stomach, just imagine, I'm drawing over here, when the food enters into this part of the stomach, that is into the antrum. Okay, so if whenever it enters into the antrum, there is distension of the antrum, and this leads to stimulation of the G cells. I told you the G cells are the hormonal cells that are present in the stomach. So the G cells produce gastrin, that is a hormone that further will act on the parietal cells, and it will cause release of hydrochloric acid. Okay, so literally 70% of the total hydrochloric acid secretion depends on this phase, on the gastric phase. Okay, and then you have 20% depending on the cephalic phase, and the last phase that we have is your intestinal phase. So 10% of your gastric acid secretion depends on the intestinal phase. All right, so this occurs when the food enters into the intestine, and there will be release of chyme into the small bowel. Okay, digested food or chyme into the small bowel. So this is all your phases of gastric acid secretion and all that they will ask you in the exam about it. 3 phases: cephalic phase, gastric phase and intestinal phase. Okay. All right. Now sometimes they will ask you which of these is a function of gastric acid. All of these are functions of gastric acid except. So can anyone tell me what are the functions of gastric acid? Any idea? Give me 2-3 function of gastric acid. It's very easy. Doctor and caffeine, how stress ulcers are formed, we'll see ahead. Don't worry. We have a whole section on gastric ulcers. What are the functions of gastric acid? Anyone? Okay. So the first thing obviously is to digest the food. Okay. So the main component of the food that needs to be digested is protein. To digest this protein, to break down the protein into polypeptides, you need something which is called as pepsin. Okay, pepsin. Now, pepsinogen is produced by the chief cells. That's what we saw. Conversion of this pepsinogen to the more active form, that is pepsin, requires hydrochloric acid, okay, or gastric acid. So that is the first thing that gastric acid does. The second thing that gastric acid does is it promotes production of duodenal secretin. So secretin is also required for digestion of your food. So the second thing is gastric acid will promote the release of duodenal secretin. Okay. Third thing, it maintains an acidic environment in the GIT. So it prevents bacterial colonization in the GIT. And the fourth thing that happens is it helps in formation of chyme. Okay, it helps in formation of chyme. What is chyme? Chyme is nothing but very small food particles. So food particles, digested food particles which are less than 1 mm in size and they are mixed with saliva, that is called as chyme. Okay. So these are all your functions of gastric acid. Now guys, please remember, you all will say, why is ma'am teaching us this theory part? This is not theory part. This comes in the exam. They will simply ask you a question as one of these, all of these are the functions of gastric acid except, and they will give you some third, some other option which will not be the answer. So if you know these 4 options, you will be able to rule out what is the correct answer. All right. Stomach is like super important topic for the exam, and that's why you should know everything about it. All right. Now, H. pylori ulcer is most commonly found in intrum, fundus, small intestine, or body of stomach. H. pylori ulcer is most commonly found where? Intrum, fundus, small intestine, or body of stomach. Okay. So in some Dr. Caffeine Mulai Vendan, all of y'all are answering this as intrum of the stomach. Are you sure that is the answer? Okay. So H. pylori ulcer is most commonly found in the small intestine. That is the answer. I just divided the stomach into different parts to confuse you guys, but only Staphylococcus has answered that correctly. H. pylori ulcer is most commonly found in the small intestine only. All right. It is not in the fundus of the stomach. It is not in the intrum of the stomach. It is in the small intestine. Okay. All right. So moving on to the everything about H. pylori that you need to know. All right. So first, can you tell me whether H. pylori was founded by whom? This is one of the most important questions that has come previously in the exam. Once they also gave the name of those scientists, because both the scientists got a Nobel Prize for finding that H. pylori organism in the stomach. Anyone? Do you remember the names of the scientists who found H. pylori? Okay, I'll tell you what is the name. Their name is Warren and Marshall. Okay, Warren and Marshall. They are the ones who got a Nobel Prize for finding out about H. pylori. Okay, H. pylori is a gram-negative flagellated organism, and you need to know what is the pathogenesis by which H. pylori produces ulcers. Okay, so H. pylori produces gastric ulcers, it produces duodenal ulcers, it can even cause malignancy. So it can cause CS stomach because of chronic ulcers. So all these things are produced by H. pylori. But how does it exactly produce? So your H. pylori produces an enzyme called as urease. Okay. Now what does this urease do? So this urease will convert urea to ammonia. And this is coming from H. pylori, correct? Now what does this ammonia do? So ammonia gives a negative feedback mechanism to the G cells, okay, and it tells the G cells produce more and more gastrin. So the G cells produce more gastrin. This gastrin will further act on the parietal cells and it will lead to more and more production of hydrochloric acid. So this is how it increases the acidity in the stomach, in the duodenum, and it causes increase in gastric and duodenal ulcers. Okay, so what does all this acid do? First of all, it will break down the mucosal barrier that is there of the stomach, and it also increases the inflammation in the stomach, causing gastritis and ulcer. Okay, so that is how your H. pylori acts. That is how the G cells react to the negative feedback mechanism of H. pylori. Now the next question that comes in the exam, from exam point of view, what do you need to know? So you need to know from the exam point of view what are the toxins that are produced by the H. pylori. Okay, so this is something that they ask very commonly. So the first toxin that it produces, obviously, that we have seen is urease enzyme. The second thing is produces certain cytotoxins. So these cytotoxins further break down the cells of the stomach, and this has come in the exam before. CAG-A and VAC-A. These are the two cytotoxins that are produced by the H. pylori, which can further increase the inflammation in the stomach. Alright. Now, the next thing that they ask in the exam is what is the route of spread? So, you know that H. pylori is often found in developing countries. It gets transmitted from one person to another, correct? But what is the route of spread in H. pylori? Yes, doctor, and caffeine, you are absolutely correct. The ammonia will positively stimulate the G cell, or by negative feedback mechanism, it will positively stimulate the G cell to produce more gastrin. Okay. All right. It's telling the G cells that there isn't enough hydrochloric acid, so produce more and more hydrochloric acid. So as a result of this, it will produce more gastrin, which will further go and increase hydrochloric acid release. Yes, very good. Staphylococcus and doctor and caffeine, that is a very peculiar name. All right. So the route of spread is fecal-oral route. Absolutely correct. And that is why it is found mostly in developing countries where there is not much sanitation, where there is not much drainage system that is in place. Okay, it is also in the developing countries more common in the lower socioeconomic group. Okay, now how do you diagnose? What are the 3 tests that will help you identify? And this comes very importantly in the exam. Very important question. 3 tests that will help you diagnose H. pylori. Out of this, 2 are non-invasive tests and 1 is an invasive test. So tell me the 2 non-invasive tests and the invasive test. I'm going to wait for you guys to answer this one instead of me giving the answer. Yes, very good, Faiz Ibrahim. So invasive test is you will do a gastroscopy or an upper GI scopy and biopsy. Okay. Non-invasive may urease breath test, very good. So that is also called as the rapid urease test. That is a non-invasive test. Anything else? Can you send labeled particles of any one particular element and help to identify H. pylori? Labeled urea breath test. Have you all heard of that? Okay. So you can also do the labeled urea breath test. That is also a non-invasive way of identifying H. pylori. Okay, so these are the 3 tests that will help you to identify H. pylori. Out of these 3, which will be the gold standard? That is the thing that will come as a question in your exam. What is the gold standard test for diagnosis of H. pylori infection? Yes, absolutely correct. So your gold standard will always be biopsy. Okay. So you'll do a biopsy, and you, whatever you collect in the biopsy, you will culture it and you will see the growth of this flagellated gram-negative organism called H. pylori. Okay. The next thing that they will ask in the exam is what is the treatment of H. pylori infection. So now there are three combinations, triple combination therapy by which you can treat H. pylori infection. So can anyone tell me what is, tell me even one combination and I will give you a virtual chocolate. So all of you who have come in late, we have been doing stomach and duodenum today. We are now discussing H. pylori, who founded it, what was the pathogenesis of H. pylori, the toxins produced, route of spread, diagnosis and treatment. All right. Yes. So the first, absolutely correct. The first one that you need to tell me is that all the regimens has two PPIs. Okay. All the regimens will have two proton pump inhibitors and it will have one antibiotic. Okay. So the first regimen can have clarithromycin. How much clarithromycin? Even that you need to know exactly. Okay. So 500 mg BD of clarithromycin, or instead of clarithromycin, you can give amoxicillin. Okay. How much amoxicillin will we give? Same 500. Just remember 500. It's actually 500 to 750, but you can remember the same 500 BD. Okay. Or you can also use tetracyclines. So this is the first one along with two PPIs. All right. The second combination that you need to take is either metronidazole or tinidazole. So the first drug will be either clarithromycin, amoxicillin or tetracycline. The second drug that you will take in this is metronidazole or tinidazole. And the third drug will be the PPI. Okay, so you will give, I forgot to give you the dose. Metronidazole will be 400 BD and tinidazole will be 600 BD. And the third thing is the PPI. So either you can give omeprazole 20 mg BD. Remember, everything is twice a day. Everything is twice a day. Okay. Or our favorite pantoprazole. Pantoprazole, everyone knows the dose, 40 mg BD. Or you can give lansoprazole. So lansoprazole is 30 mg BD. Okay. So what are you giving over here? Sorry, you're giving two antibiotics and you're giving one PPI. All right, two antibiotics and one PPI. That is our triple therapy for H. pylori infection. The question asked in the exam is how often, for what is the duration of therapy? Anyone, what is the duration of therapy? So suppose I want to treat someone for H. pylori infection, I can give them clarithromycin 500 BD plus metronidazole 400 BD plus omeprazole 20 mg BD. Okay, so similarly take one antibiotic from the first group, one antibiotic from the second group and a PPI from the third group. All right. Okay, what is the duration of treatment? Yes, duration of treatment is minimum of 7 to 14 days. And after the 14 days, what do? You stop the antibiotics and you continue with the PPIs at least for 1 month. All right. Okay. Now, the next question that we come to. So that was all about H. pylori infection. Now you have to come to a different pathology. A child comes with a palpable olive-shaped mass in the abdomen, constipation, vomiting and anorexia. What drug would the child have been treated with during the first 14 days of life? Amoxicillin, metronidazole, erythromycin or piperacillin? Okay, so all of you all have given the correct answer. Absolutely correct. All of you all have mentioned it as erythromycin. Okay, so what is it that we are talking about over here? No, it is not intussusception. It's not intussusception. Anyone, can you tell me the diagnosis? Jaldi batao diagnosis. Olive shaped mass in the abdomen. He's having constipation, vomiting, anorexia. Yes, very good, Faiz Ibrahim. So this is congenital hypertrophic pyloric stenosis. Okay. So what happens in this? This is your stomach. This is the pylorus. Pyloric sphincter will be here. So there will be hypertrophy of the muscle of the pylorus. Okay. So there will be hypertrophy of the musculature of the pylorus or of the pyloric antrum. And which muscle is the one that is hypertrophying? Just remember, I'll draw it over here so that you remember. So the circular muscle that is there of the pylorus, that is the one that will hypertrophy. So when it hypertrophies, what happens? There is a pyloric sphincter, correct? So the pyloric sphincter does not relax. So if it does not relax, what happens? The food that is there, whatever food he is eating, will not pass into the duodenum. It will stay in the stomach. It will increase the intragastric pressure. So because of increase in the intragastric pressure, what will happen? The child will have vomiting. Okay. Then the food is not passing ahead into the small intestine and large intestine. So he will have constipation. Okay. And because of less absorption of food, you will also have anorexia. All right. So these are the three things that you will see as the causative, as the clinical features in a child who has CHPSS. All right. Now, as I told you in the exam, they ask in the first 14 days of life, if you treat a child with azithromycin or erythromycin, there are high chances that the child develops CHPSS. Okay. Now, along with these symptoms, there is one sign. So the sign is when the doctor palpates the abdomen, he will feel an olive-shaped mass. That olive-shaped mass is nothing but this part of the stomach that has hypertrophy, the antrum of the stomach that has hypertrophy. Okay. Now, the next thing that you need to know is one important question that comes in the exam. So, can anyone tell me what is the electrolyte imbalance that you see in this case? What is the electrolyte imbalance that a child of CHPSS presents with? Anyone, any idea? Correct. So the electrolyte imbalance. So what are you doing? The child will vomit out all of this food, and along with the food, it will vomit out the hydrochloric acid that is produced in the stomach. Okay. So he is vomiting out the hydrochloric acid. So because he is vomiting out H plus, that is the acid, so you will have alkalosis. Because he is vomiting out the chloride, so you will have hypochloremic metabolic alkalosis. Okay, so there is hypochloremic metabolic alkalosis. All right, so that is the electrolyte imbalance that you will see in case of CHPSS. All right, now the next question that they ask in the exam is how do you diagnose? So the diagnosis, one obviously is by clinical examination. You see a small child, constipation, vomiting, and having olive-shaped mass, automatically you can come up with the diagnosis of CHPSS. The second thing that you can do is an ultrasound, and the third thing you can do is an X-ray. Okay. So in an X-ray, what do you get? Someone has already mentioned over here. You get a single bubble sign. All right. And on USG, what is the sign that you see? You see a target sign of the hypertrophied circular muscle, and this is also called as what? This is also called as donut sign. Okay, not just target sign, but it is also called as donut sign. Okay. Now, to be more specific, if they ask in the exam, they will want to know what is the length of the pyloric canal and what is the thickness of the pyloric canal that you see in CHPSS. So that is also very important. So your pyloric canal will be slightly elongated. So the length of the pyloric canal that you get is 14 mm, okay, or more than 14 mm, and the thickness of the pyloric canal obviously will be increased because the circular muscle has hypertrophied. So the thickness of this pyloric canal will be how much? More than 4 mm. Okay, so these are the two numbers you need to remember for your exam. All right. Okay. Now, next thing, there is one more modality, radiological modality of finding out CHPSS, and that is barium swallow. Okay. So on barium swallow, what is the name of the sign that you see? Anyone? It is a contrast, correct? So the food will get stuck over there. So it shows a railroad track sign. Railroad track sign. You, for the sake of your exam, na, you need to know all of these names. This donut sign on USG, single bubble sign on X-ray, railroad track sign on barium swallow. All these things you need to remember because they will ask in the exam. Specifically, every year they cannot keep asking you what is the causative factor of CHPSS, alright, or what is the treatment of CHPSS. Sometimes they will want to ask thoda bahut andar ka, alright. Okay, now moving on to the treatment. So what is the surgical treatment of CHPSS? Everyone knows the answer. Obviously you have to cut out the hypertrophied muscle. So if the if the muscle is hypertrophied like this, you will cut it out longitudinally, but you will not cut it. You will have to make sure that the mucosa is intact. Okay, mucosa is the innermost layer of the stomach, so you have to make sure the mucosa remains intact, otherwise you will have leakage of the food into the peritoneal cavity. Okay, so this is called as Ramsted's pyloromyotomy. So you're cutting the muscle of the pylorus. That is why pyloromyotomy. Okay. So that is our surgical option for CHPSS. All right. Okay. Yes, you keep the mucosa intact. Okay. So we've done the whole of CHPSS. Now the next thing that we need to do is the types of gastritis that you have. Okay, so you have different types of gastritis. Now you need to tell me the gastritis due to H. pylori is also called as what type of gastritis? Type A gastritis, type B gastritis, erosive gastritis, or stress gastritis. So there are nearly 6 types of gastritis. It's very easy to remember all of them. I will just quickly do it with you all. Yeah, so most of you have answered it correctly. It is B. Type B gastritis is caused due to H. pylori. So quickly tell me, what is the cause of type A gastritis? Very easy to remember. In fact, there is a small mnemonic to remember this. Okay, so A is autoimmune cause. Remember, A is autoimmune cause. So this is caused due to anti-parietal cell antibodies. Okay, there is production of anti-parietal cell antibodies. So when the antibodies act on the parietal cells, they start destroying them. There is achlorhydria, and because of the achlorhydria, the parietal cells are not able to produce enough hydrochloric acid. The G cells that are there in the antrum, okay, they will start. Okay, I'll draw it and show it to you instead of telling you just like that. Okay, so imagine there are parietal cells in the stomach. There are antibodies against these parietal cells, so these cells get attacked. So these are the ones that produce hydrochloric acid. So because they get attacked, there will be achlorhydria. Now, in the antrum of the stomach, you have the hormonal cells, that are the G cells. So because there is achlorhydria, the G cells get stimulated and they start producing excessive gastrin. Okay, and because of this excessive gastrin, you will have hyperstimulation of the remaining parietal cells and you will have excessive production of hydrochloric acid. So that is the cause of the type A gastritis. So that's how you remember. Type A gastritis is because of autoimmune causes, anti-parietal cell antibodies. Okay. Now, type B gastritis, B for bacteria. So type B gastritis is due to H. pylori infection. Okay. So they'll ask you in the exam, which is the part that is most commonly affected in the stomach due to H. pylori infection. So in the stomach, it is antrum. Okay. And overall, if you see, it is the first part of the small intestine. Okay. All right. The third type of gastritis that we have is the reflux gastritis. So any idea, reflux gastritis usually occurs when? Yeah, doctor and caffeine, very good. A is autoimmune, B is bacteria. Reflux gastritis is always after a surgery. Remember that. Okay, if you do a gastric surgery and you cut the stomach short, then because of the shortened stomach, the stomach will move up through the gastroesophageal, the gastroesophageal junction will move up through the hiatus. Okay, so that will lead to reflux gastritis. So basically, it is nothing but GERD, and this GERD is after gastric surgery. Okay, the third type of gastritis that we have is erosive gastritis. Any idea why is erosive gastritis present? Many people have this because of NSAIDs in doctors, so it's very common because we pop anti-inflammatory left, right, and center, and it can also be due to alcohol. Okay, so there is erosion of the mucosal layer of the stomach which causes more gastritis. The next type of gastritis that we have is stress gastritis. Okay. All right. So these are all the different types of gastritis that we have. Type A, type B, reflux, erosive, and stress gastritis. All right. Okay. Moving on to our next questions. Next question. Curling's ulcers are seen in a patient of. Head injury, acid attack, H. pylori infection, or burns. Mugil, wow, I'm very happy that you have passed the exam and the classes have been useful to you all. So, for those of you who don't know what classes he's talking about, in fact, I think in November end and December, I had started, no, November only, I had started the mission FMG series for medicine. So, I had completed the entire portion of medicine, just like I'm completing the entire portion of surgery for you guys now. I had completed the entire portion of medicine for the FMG students. So many of them have messaged me saying that that was very useful, and that's where I got the idea to start surgery also for you all, because these four major subjects that you have, medicine, surgery, pediatrics, and OBGY, I've seen most of you all leaving the final year subjects and going for the exam thinking कि अभी पढ़ा था final year, अभी time नहीं है, let me concentrate on patho, pharmac, micro and anatomy. So what happens is you all miss out on many, like literally 30% of the questions, because most of them are based on final year subjects. So it's very important that you spend at least 1 hour every day, just the way I am taking these classes for you guys to revise your final year subjects. Because remember, you tell me right now, simple questions like this: curling ulcers are seen in a patient of burns. Yes, most of you all will remember this. But those questions that I asked you before, about gastritis due to H. pylori is which type of gastritis, or nerves of lateral jet supply, which part of the stomach, all those things you all will not remember during the time of the exam. So that's why it's very, very important for you guys to revise through these classes. Trust me, I'm literally reading the textbooks for you all and treating you all and teaching you all for these classes. Every day I will read the chapter and teach it to you all, and that's why you don't need to go anywhere else for this, because all this information is coming from the textbook. Okay, yes, I had also taken the short subjects, which I'm again planning to take up for this for you guys again. So remember to follow these classes, also share it with your friends, and it will be useful for all of you. Okay, all right. So moving on to curling ulcers. Okay. So curling ulcers are basically seen in patient of burns. Other gastric ulcers that they will ask you about is Cushing's ulcers. So everyone knows about Cushing's ulcers and curling ulcers. Cushing's ulcers is seen in patient with head injury. Correct? Okay. Now, next thing that they will ask you is, how does a patient present with? So, clinical features of a gastric ulcer. They will There will be a very specific line that will be given if they want you to pick up about gastric ulcer, and that is about acute pain in epigastric region. Okay. So, the patient will present with acute pain in epigastric region and vomiting. Now, this vomiting can be, if there is a bleeding ulcer, it can also cause hematemesis. Okay, and sometimes there can be perforation. If there is perforation, then, so I'm just writing, these are the complications. Perforation, the patient will present with a very rigid abdomen. All right, so these are the things that will help you identify a gastric ulcer: acute pain in epigastric region and vomiting. Now, how will you treat? That is the question they will ask you in the exam. So remember, there are three main things that you need to do. First thing, always IV ranitidine 50 mg TDS thrice a day. The second thing that you need to give is IV fluids to the patient. He will not be able to eat anything. And the third thing that you need to give is IV PPI. So IV pantoprazole. Okay, I'll just write PPI over here. So the question that comes in the exam is, a patient comes to you with acute pain in the epigastric region and vomiting. What will be your, this patient recently had a history of burns, what will be your treatment for this patient? Okay, so in the options they will give you something like you will give oral PPI, you will give oral ranitidine, and the third option will be you will give IV ranitidine, IV PPI and IV fluids. Everything has to be given intravenously, and you have to then convert it, once you have stabilized the patient, then convert it into oral drugs, and these oral drugs need to be continued for 4 to 6 weeks. Okay, all right. Now, very important question that comes in the exam. It has come many times before. I don't know if you all will know the answer to this or no, but it's one of the most important questions that is there in today's class. So bleeding gastric ulcer is caused due to erosion of which artery? Left gastroepiploic artery, left gastric artery, right gastroepiploic artery, or right gastric artery? Batao. So Staphylococcus is saying A. Doctor and Caffeine is saying B, left gastric artery. Sujata is saying C, right gastroepiploic. Okay. All right. So most of you have mentioned the answer as B. That is absolutely correct. So your bleeding gastric ulcer is caused due to erosion of the left gastric artery. Okay. Now, questions that they ask about gastric ulcer. Acute gastric ulcer involves which layers? Chronic gastric ulcer involves which layers of the stomach? Okay. So if you see the stomach from inside to outside, what do you have? You have mucosa, you have submucosa, and you have the muscularis layer, and you have the serosa. Now, based on these 4 layers of the stomach from inside to outside, tell me acute gastric ulcer involves which layers and chronic gastric ulcer involves which layers? Yes, very good. So, your acute gastric ulcer will involve only the inner layers. Okay, so your acute gastric ulcers will involve only your mucosa and submucosa. While your chronic gastric ulcer will also involve the muscularis layer, and that is very important because the more chronic it is, if it involves the muscle, that will cause contracture of the muscle. So contracture of the muscle will give the stomach a deformity. What is the name of that deformity also? You need to tell me. I think I must have put a picture ahead, so I'll just show you ahead. So in chronic gastric ulcer, you have involvement of mucosa, submucosa, and muscularis. Photo. Yeah. So this is the picture that I wanted to ask you guys about. Tell me. So this is the normal stomach, and the most common area or site where you get a gastric ulcer is along the lesser curvature. All of us know that, correct? So because of involvement of the muscularis layer for a chronic period of time, this is the loss of curvature that happens and distension of this part that happens of the greater curvature. So what does the stomach look like? Yes, very good. So you get a hourglass deformity, or it is also called as a teapot deformity. Okay. So the stomach will have a hourglass or a teapot deformity. So please remember this for the exam. Okay. So on chronic involvement into the muscularis layer, and also when it perforates, it gives it a hourglass or a teapot deformity. Okay. Now the next question that they will ask you in the exam is, what is the most common site of gastric ulcer? We are talking about gastric ulcer now, guys. If they ask about peptic ulcers, please don't get confused. Peptic ulcer will also involve the small intestine. So in that, the answer would be duodenum. But we are talking about gastric ulcer. Most common site of gastric ulcer is the lesser curvature of the stomach. Correct? Now, the next thing that they will ask you is, what is the characteristic clinical feature? So, sorry. In this, can you tell me the patients will have weight loss or weight gain in gastric ulcers? Patients in gastric ulcer will have weight loss or weight gain? Pain after eating food. Very good. So whenever the patient eats food, okay, so he'll eat food, he will get pain. So he will be scared to eat food. So because he's scared to eat food, he will have weight loss. Okay. So this is the main difference between gastric ulcer and duodenal ulcer. In duodenal ulcer, on eating the food, the patient will feel better. The pain will actually reduce. So he will eat more and more food, and that's why he will have weight gain. Okay. On the other hand, in gastric ulcer, you will have weight loss because on eating food, the patient will get pain. Okay. Now, the next thing that they will ask you in the exam is, what are the complications? So, complications of gastric ulcer. So, anteriorly, it may perforate into the liver. Okay, anteriorly it may perforate or penetrate into the liver, and posteriorly it may perforate into the vessels that are there around the pancreas. Okay, so there are vessels around the pancreas, and that will lead to a lot of bleeding from the splenic vessels or left gastric vessels, all that are present around the pancreas. Okay, so these are your anterior and posterior perforation. Now, how do you identify? What is the investigation of choice for a gastric ulcer? Investigation for a gastric ulcer? We are talking only about gastric ulcer here, huh, guys? That's what I need to keep reminding you. That's why it's so specific. Yes, so the best thing to do is to do an endoscopy, and you will see the ulcer. That is the gold standard. Okay, or endoscopy, they can also call it as upper GI scopy. Now, the second thing that you can do is you can do a barium meal follow through. So in a barium meal follow through also, you will be able to see a niche and a notch pattern. Okay, what do they say? A niche and a notch pattern. Okay, so what is a niche and the notch pattern? So where the ulcer is, you will see something going down like that. So that is called as the niche, and the greater curvature of the stomach will distend compensatorily. So that is called as a notch. Okay, so the niche and the notch pattern. Okay, all right. Now, investigations are done. What is the treatment? Treatment is very easy for gastric ulcer. You will continue those drugs that I told you. Now, if he is suffering from H. pylori, then of course you have to start him on triple therapy. If he's not suffering from H. pylori, if there are other reasons, then the basic drugs that you need to give are H2 blockers, PPIs, all those, then those bismuth containing liquids that help in maintaining the gastric mucosa integrity. Okay. Alright, next question that we have is, what is the surgical treatment? So can anyone tell me the surgical treatment of the part of the ulcer? Surgical treatment. Okay. So surgical treatment is nothing but you have to do a gastrectomy plus a drainage procedure or a reconstruction. Okay. Now, what is the gastrectomy? Proximal or distal gastrectomy? What you do is, this is your stomach. Okay. So this is the part, the antrum part that contains the G cells, the cells that produce gastrin. So you do a distal gastrectomy. You do a distal gastrectomy. Now you have to connect this proximal part of the stomach to drain the food into the small intestine, correct? So you have two options. So we have, from these two options, we have two surgeries. We have Billroth 1 and we have Billroth 2. So just remember, in Billroth 1, you are connecting the proximal part of the stomach to the duodenum. Okay, so you are doing a gastroduodenostomy. Okay, and in Billroth 2, you are connecting this proximal part of the stomach to the jejunum. So you're doing a gastrojejunostomy. Okay, you're doing a GJ or a gastrojejunostomy. All right. So that is the difference between your drainage procedures, Billroth 1 and Billroth 2. So both of them will have distal gastrectomy. Along with distal gastrectomy, you will have a separate drainage procedure, either Billroth 1 or Billroth 2. Billroth 1 may gastroduodenostomy and Billroth 2 may gastrojejunostomy. All right. Okay. Understood? And the last question that will come about gastric ulcers in your exam is malignant transformation of gastric ulcers. So what is the, if a gastric ulcer becomes malignant, what is the type of cancer that will occur? Is it squamous cell carcinoma? Is it transitional cell carcinoma? Is it something else? Anyone? Gastrojejunostomy is always preferred. It's not easy to move the duodenum. The duodenum is a fixed structure. So as a result of this, doing a gastroduodenostomy, mobilizing the duodenum is more difficult. So gastrojejunostomy is always preferred. Yes, very good. So, Dr. and Caffeine, you're correct. So, the malignant transformation of gastric ulcer takes place into an adenocarcinoma of the stomach. All right. So, this was all about gastric ulcers that you need to know. What are the different types? What is the most common site? What are the clinical features, complications, investigation, treatment, malignant transformation, and surgery. All right. Everything about gastric ulcer is done. Now, let's move on to the next question about gastric ulcer. So, which of these is false regarding benign gastric ulcers? Sorry about the spelling mistake. About benign gastric ulcers. Floor contains necrotic tissue, mostly present along lesser curvature. Margins are regular. All of the above statements are true. Okay, so Dr. and Caffeine is saying A, Staphylococcus is saying C. Answer changed to A by Staphylococcus. Okay. Okay, so most of you have answered it correctly. So the floor cannot contain necrotic tissue. If it is a benign gastric ulcer, the floor will have normal granulomatous tissue. All right, so let's see what are the differences between benign gastric ulcer and malignant gastric ulcer. I'll write the topic. You tell me how it will be. Okay. So, where is the site of benign gastric ulcer? For that is the first question. How are the margins of benign gastric ulcer? Benign versus malignant. Okay. Site, margin. Then third will be the floor contains what kind of tissue. Okay. How are the edges of the ulcer? And what is the first thing? How is the surrounding area of the, that I'll write it over here. Surrounding area. Okay. Yes. So in a benign gastric ulcer, the most common site is the lesser curvature. Okay. But in a malignant gastric ulcer, the most common site is actually along the greater curvature. Okay. All right. How are the margins? This is very simple. The margins of a benign gastric ulcer will be regular margins, and anything that is malignant will always have irregular friable margins. Okay. Then the floor of the benign gastric ulcer will have normal granulation tissue, and malignant ulcer will have necrotic tissue. Okay, that's how it shows that it is aggressive and malignant, by all these irregular margins, necrotic tissue, all of this. Then the edges of a benign gastric ulcer will be punched out edges. Okay, so it will look directly like this, regular and punched out. Okay, on the other hand, the malignant gastric ulcers will have everted edges like this, rolled out or everted edges. Okay, the surrounding area that is there around the benign gastric ulcer will be normal, and along the malignant gastric ulcers, the surrounding areas will show irregular tissue, it will show necrosis. Okay, so you will know that it is a aggressive ulcer. Okay, and that's it. So that is the difference between your benign and malignant gastric ulcers. Okay, so they can ask in your exam any of these topics, like identify what is false about benign gastric ulcer or false about malignant gastric ulcer, and you should be able to answer. Okay, all right. Now next question for you guys. Which of these is false regarding duodenal ulcers? So from gastric ulcers, we move to duodenal ulcers now. So which of these is false regarding duodenal ulcers? Weight loss is common, more common in males. Melena is seen. Pain comes periodically. Very easy to identify because we have just discussed gastric ulcer. So you should be able to differentiate between gastric and duodenal ulcer easily. Okay, so we have most of you saying weight loss is common is wrong, and then we have Staphylococcus saying B, more common in males. Okay. So first of all, tell me, when we talk about duodenal ulcers, what is the most common site of duodenal ulcer? That is the first question that comes. Okay. Then, what is a kissing ulcer? This is also something that they like to ask in the exam, kissing ulcer. And the third thing that they will ask you is, what are the complications of duodenal ulcers? And then we'll see what is the difference between gastric and duodenal ulcer. So what is the most common site of a duodenal ulcer? Anyone? Yes, absolutely correct. So the most common site of a duodenal ulcer is the first part of the duodenum. Okay. Now, when do you call duodenal ulcers as kissing ulcers? Anyone? Yes, very good, Fez. So, if you have two ulcers, okay, one ulcer is present along the anterior surface of the duodenum, and the second ulcer is present along the posterior surface of the duodenum. If you have these two ulcers and the anterior and posterior surfaces are touching each other, then that is called as kissing ulcers. Okay, that is called as kissing ulcer. And based on this only, you have the complications of duodenal ulcer. Okay, yeah. So your anterior ulcers that are there, or basically the duodenal ulcers that are present on the anterior surface of the duodenum, the complication that occurs with them mostly is that they perforate. Okay, while your posterior ulcer that is there, it will try to go into the blood vessels. So your left gastric artery and your splenic vessels that are there, it will go into the arteries and it will bleed. So anterior perforates and posterior bleeds. Okay, it can even penetrate into the pancreas that is just there below, so it can also penetrate, but mostly it bleeds. That's what they ask in the exam. It's one of the major places where they try to confuse you for the exam. So I'm marking this as a question. Remember, okay, posterior will bleed. All right. Now, what are the major differences between a gastric ulcer? One second. Major differences between a gastric ulcer and a duodenal ulcer. So I will write the topic, subtopic, and you have to tell me about it. So, when do you get the pain? What is the time of getting pain in this ulcer? Then, sorry, so sorry, one second. Okay, so when do you get the pain? Yeah, very good. I want you guys only to answer. So, Staphylococcus is saying in gastric ulcer you get pain after food intake. Very good. So, on eating, you get pain. So, if on eating you get pain, that means the person will be very scared to eat because he will be scared that he'll get the pain. So, he'll eat less. So, because of that, he will get weight loss. On the other hand, in duodenal ulcer, what are you getting? You're getting pain. The pain will reduce on eating. Okay, so you get before food intake. When the duodenum is empty, at that time you will get the pain. Okay, so because of that, when you eat food with food, the pain will reduce. So you will eat more and more food. So you will have weight gain in this. Okay. Anything about the predilection of the sex? Anything that in males you have more common gastric ulcer, or in males you have more common duodenal ulcer? Anything like that? Okay. So remember, gastric ulcers is found equal in both the sexes. Okay. So it's present in males and in females in equal numbers. Your duodenal ulcer is most commonly seen in males. Remember this. All right. Okay. Then what about hematemesis and melena? Okay. So If we are talking about gastric ulcers, it's more common that you will throw out the blood outside. So you will have more of hematemesis. On the other hand, if you're talking about duodenal ulcers, the blood will tend to go down from the duodenum into the large intestine and then down through the stools. So there will be more chances of melena. Okay. Then periodicity of symptoms, that is important. So do the symptoms come in clusters at certain periods in time, or are they there all the time? Okay. So periodicity is less in gastric ulcer. So in gastric ulcer, you literally be having pain all the time. On the other hand, in duodenal ulcer, you will have more periodicity. That is, in one cluster, you will have pain and symptoms. Then after 2 to 3 days, you will have normal. Then again, in one cluster, you will have pain and symptoms. Okay. So that is the difference between gastric ulcers and duodenal ulcers. Okay. All right. So now we've already done what all of duodenal ulcers. Okay, that went away. So we had done the most common site of the duodenal ulcer, what are kissing ulcers, what are the complications. Now in the complications of duodenal ulcer, add 2-3 more complications. Okay, so we had seen that the anterior one will perforate and the posterior ulcers will bleed. Okay, along with that, you need to know, because of constant or chronically occurring ulcers, you can also have scarring of the duodenum. Okay, so that scarring of the duodenum can lead to pyloric stenosis, okay, or stenosis of the first part of the duodenum. All right. So those are all the complications that you get. You can also have secondary infection, so abscess formation, not very important from point of view of the exam. I think you moved the mic. Your voice has become static. Can you hear me now, Mugil? Okay. All right. So the next definition that you have is that of a giant duodenal ulcer. So when do you call a duodenal ulcer as a, sorry, I just kept my phone, actually I was seeing your messages, so I kept it on the mic, I think, so that's why you guys were not able to hear it. Okay. All right. So when do you call an ulcer as a giant duodenal ulcer? You call an ulcer as a giant duodenal ulcer when it is more than 2 centimeter in size. Okay. This is one important question that comes in the exam. Giant duodenal ulcer is any ulcer that is more than 2 centimeter in size. Okay. Now moving on to how do you investigate a duodenal ulcer. So in this picture, can you tell me what am I trying to show you exactly? How much questions left? Just another 5 minutes. Mulay. So what are the investigations? First of all, remember, if you think that the ulcer is caused by H. pylori, so then you will do all those investigation. You will do rapid urease breath test, you will do the carbon labeled breath test, and you can do gastroscopy and biopsy. Okay. Other than that, if it's not because of H. pylori, how do you find out? You can do a gastroscopy or an upper GI scopy. That is the best way to find out exactly what is the site, what is the extent of the ulcer, and what are the complications that the ulcer is causing. Is it causing any narrowing? Is it causing any scarring over there? Okay. Now, the next thing that you need to do or know for the exam is a barium swallow. So on barium swallow, you get this very peculiar appearance. Okay. So that appearance is called as a trifoliate appearance. So this is your, can you see? You have barium over here, you have barium over here, and you have barium over here. But in these parts, you don't have barium. Now, why does this? So you can see like a trifoliate, like 3 leaves you can see over here. 1, 2, 3. Okay. So why do you have this on barium swallow, trifoliate appearance? Okay. So remember, whenever you have these gastric ulcers for duodenal ulcers for a long period of time, you will have spasm along the duodenal cap. You will have cicatrization or scarring along some layers of the wall of the duodenum. So because of that, some areas will not have the food material in it, and some areas will have the food material in it. So some will light up with barium and some will not light up with barium. That's why you get the trifoliate appearance. Okay. Along with the scarring, you will also get presence of secondary diverticula. Okay. So what happens is, suppose, just imagine, this is the duodenal cap, the first part of the duodenum, upper part, duodenal cap. So in the duodenal cap, it will undergo spasm. Now this is where the ulcer is. So this part has undergone scarring. Now initially it undergoes scarring and later on it forms a diverticulum, secondary diverticulum. Okay, so the barium will go inside this diverticulum. So that is one more diverticulum. So that is how you get the trifoliate appearance in barium swallow. Okay, or barium meal follow through. Sorry, not barium swallow, barium meal follow through. Alright, barium swallow is mainly for esophageal problems. Barium meal follow through will be for your duodenal problems. Okay, alright, so this is about duodenal ulcer. Now last part that we need to discuss is what is the treatment. So the treatment, as always, what are the drugs that you will be giving? You'll be giving PPIs, you will be giving H2 blockers like ranitidine, you will be giving triple therapy if there's H. pylori, and you can also give prostaglandin analogs. Remember this, there are some prostaglandin analogs that help in maintaining the mucus production and the mucus lining of the stomach and the duodenum, and that is PGE1 analog, and that is misoprostol. Okay, other than this, what is the surgical treatment? So for surgical treatment, you want to reduce the amount of gastric acid that is produced. So to reduce the amount of gastric acid, you need to cut the innervation of the parietal cells. How do you cut the innervation of the parietal cells and the innervation of the antrum? By cutting the vagus nerve. So you need to do a vagotomy. Okay, so now there is one procedure by which you can. So remember, now if this is your stomach, so what is the use of your vagus? Your vagus will not just help in acid production, that is the first thing, but it also moves the food forward. Okay, so the propulsion of the food forward from the stomach into the small intestine also takes place because of the vagus only. Okay, so if you cut the vagus supply, suppose I cut the vagus supply completely, what will happen? The food will also remain static in the stomach. It will not move from the stomach into the duodenum. Okay, so I don't want that to happen. I want the acid production to reduce, but I want the drainage to remain normal. Drainage of the food or propulsion of the food to remain normal. So how do I do that? So I have one procedure that is called as HSV, not herpes simplex virus. It means highly selective vagotomy. Okay, so what do you do in highly selective vagotomy? So I told you what are my two problems. Acid production. Acid production is done by parietal cells, correct? So the part of the vagus that is supplying, or the fibers of the vagus that is supplying the parietal cells, I will cut them out. Okay, and the second thing that we studied in the beginning of this lecture was about the nerves of lateral jet. Okay, so you know the food is propulsed forward by the antrum, by the antral pump, and this antral pump is supplied by the nerves of lateral jet. So what I do is I make sure that I save these nerves of lateral jet. Okay, I retain or save these nerves of lateral jet, and I only cut the fibers of the vagus that are going to the parietal cells. So that way my hydrochloric acid production is less, but my drainage is maintained. So that is called as highly selective vagotomy. Now suppose I cannot do highly selective vagotomy. It's actually a very complicated procedure to do. So suppose I cannot do highly selective vagotomy. What do? I do a selective vagotomy, and there will be some problem with the drainage. So I always have to provide some kind of drainage option. So for allowing drainage of the food, instead of the food getting pushed from the stomach into the duodenum, I do a gastrojejunectomy. Okay, I directly connect the stomach to the jejunum. So the food directly from the stomach will go into the jejunum. It does not have to be propulsed forward from the stomach into the duodenum into the jejunum. Directly it will go from stomach to the jejunum. Okay, so that is what I do in case of selective vagotomy. Okay, or truncal vagotomy. All right, so this is all that we have about the gastric ulcers, duodenal ulcers. So what all have we done today? We've completed all the, I'll just write it quickly down for you over here, all the topics that we've done today. Now we've not completed the entire stomach. We have to do CA stomach also. That is also one of the things that has to be done. But since we don't have time, I will take it in tomorrow's lecture. Tomorrow's lecture is also at 3 p.m. I'm just changing the time of the lectures from 11 a.m. to 3 p.m. I hope that is fine with everyone. If there's some problem with the timing, please let me know. The reason I'm changing the timing is because in the morning there is a lot of disturbance in the place where I teach. So that's why I thought it would be easier and I would be able to focus more if I take it at 3 p.m. All right. So what all have we done today? We've done gastric ulcer, we've done duodenal ulcer, we have done CHPSS, then we've done the anatomy, blood supply of and nervous supply of both the stomach and the duodenum. Why am I specifically mentioning duodenum everywhere? Because we'll be doing jejunum, ileum, all of that in the next class, small intestine class. Okay, so whatever is remaining from this class, and then I'll be continuing it. Peptic ulcers are nothing but gastric ulcer and duodenal ulcer only. So I have taken both of them in detail for you guys. Okay. All right. Then we've done the types of gastritis. Then we have done H. pylori infection. Correct. Anything else that we have done? Yeah, I think that's all that we have done today. Then we've done physiology of acid secretion. That is also the other thing that we've done. The phases of gastric acid secretion. All right. So I hope that this class was useful to you guys. If you like the class, please don't forget to leave a thumbs up. Please also do share these classes with your friends. The better the views of the classes, the more the chances of us continuing the series for you all. Otherwise, we'll have to start off with some other series that that people actually want. So please do let me know in the comments also what are the other things that you want me to cover along with these surgery classes, and I'll be happy to take them for you guys. And I will see you guys tomorrow at 3 p.m. for continuation of this class on stomach. So little bit, 2-3 topics are only remaining. We'll do that and we'll move on to small intestine tomorrow. Okay. All right. So thank you so much and see you next time, guys. Keep studying till then. Bye bye.